Okay, good evening, everybody. Very warm welcome to you again. Another one of our Wish Wednesday presentations. Nice to see a very diverse, multidisciplinary group of participants again. I'm John Patricius here representing the Wits Institute for Sport and Health, or WISH, and we welcome you on behalf of Wits University and the Faculty of Health Sciences in particular, and also on behalf of the sponsors of these webinars, Lita and Asino Company, who've been very gracious in giving us a grant to help support the technical aspects of these presentations. As you know, this forms part of the academic offering of WISH, and we're very grateful for the feedback we have from you, and of course invite you to participate on the question and answer facility on Zoom. Please use that rather than the chat group, and we'll do our best to have our expert engage with you and answer your questions. So when we were drawing up the list of important topics, I knew that bone health would be a key issue. And you will notice that our speaker this evening is a specialist physician, which is not a coincidence, because bone health is really a medical issue in terms of how we assess and how we manage it. And perhaps not only one of our national experts, but a world expert in the field we have on our doorstep in Johannesburg, Dr. Stanley Lipschitz, was one of the first people I contacted to ask him about this topic and ask him if he would support the WISH initiative and engage with us. And he said, absolutely, but he'd like to recommend someone a bit younger than him and better looking than him to present this evening. And you had no hesitation in suggesting Hayley de Wet. Dr. Hayley de Wet is a specialist physician with an interest in bone health and osteoporosis, and we've asked her tonight to focus on that very important topic and look at it from an exercise and an athletic point of view, which she's kindly agreed to do. It is an intense topic, and I know that she's researched this particular facet of the topic quite intensely. And she's also kindly going to present us with 3 case studies, which I think will put it into great context. So, Hayley, on behalf of WISH, we welcome you. Thank you very much for giving up your time, not only this evening, but in preparing this presentation. I'm going to mute myself and hand over to you and ask you to share your screen and give you the next hour to share with us. Thank you very much.
Thanks, John. Exercise and bone. We all know that exercise is really good for us, and it's no different when it comes to the bone. Various studies have shown that most types of exercise have a really positive effect on the bone, and this includes our impact exercises, cardiovascular exercises, as well as resistance training. And obviously then an exercise that incorporates all these different types of exercises would be the most beneficial. If we just look at our goals of exercise in adults and in improving the bone, we recommend weight-bearing endurance and plyometric exercises 3 to 5 times per week. Resistance exercise of moderate to high loading at 2 to 3 times a week for a total of 30 to 60 minutes per day. So it is, it's a significant amount. Obviously, in our more elderly or frail patients, we do need to modify this and just take into consideration their safety. Having said that, exercise is still really important as it stimulates the anabolic formation of bone, and these patients really benefit, the older ones, from maintaining good balance and preventing their falls risks. But we want to really focus tonight on a bit of a younger group of patients. And here, if you look at this, it's through adolescence to early adulthood, they just say that high impact loading is the best. Well, we know this, and these are sports like gymnastics, judo, volleyball, other things with lots of force, jumping sports. These sports are associated with higher bone mineral composition, so BMD, and especially at the areas that are exposed to the impact, so specific to those anatomic regions. And it would then follow that odd impact sports would actually be more helpful. If you have a look at girls who begin strenuous activity prior to menarche, they are said to gain twice as much bone mineral content versus girls who begin after menarche, and that's quite significant. The American College of Sports Medicine therefore recommends that children and adolescents do perform these impact activities. And they've said moderate intensity resistance training, at least 10 to 20 minutes, twice a day, 3 days a week. What I also want to just highlight is that these gains that are made through this exercise in childhood are maintained throughout adulthood. So they just give you a good start. The other thing to bear in mind, it's not all just about a BMD reading in your patient in terms of benefits from exercise. Not everything is measured that we gain from exercise by the BMD. Yes, we've said the weight-bearing activity has a profound impact, and especially we see this in our female athletes where we've got that site-specific loading, and we see in both our eumenoric and amenorrheic athletes, where if you actually look at the total cross-sectional area of their bone, both their trabecular area and their cortical perimeter area are larger when compared with the non-athletes. And they had a look at this at the distal tibia. Most of new bone formation often happens at the bone surface. And if you want to make a translation here, if you see a 5.4 increase in bone mineral density, which is significant, but it might not jump out at you as being that large, it actually translates to a 64% increase in ultimate force and a 94% increase in energy to failure. So definitely significant gains. However, what we can't forget is, yes, this exercise is great, but it's the environment that the bone is in when exposed to this exercise that actually alters the benefit. And by this, we mean the nutritional status and the level of circulating hormones. So just in summary, having a look at exercise in the bone, we said that it should be dynamic, not static. There should be an adequate strain intensity. It should be discrete with intermittent bouts. There should be variable loading patterns so that different sites are being exposed. It should be supported by an optimal nutrition, which supports then a healthy hormonal axis. And there should be adequate intake of calcium and vitamin D, so just providing that healthy environment for the bone. I want to now just take a look at specifically premenopausal osteoporosis and bone mass in this age group. And I'd just like to start with a little question, and let's see if you're clear or not, or does it feel fuzzy? How do we actually diagnose osteoporosis in the premenopausal women? So these are those younger than 50 that have not menopaused. Do we make a diagnosis of osteoporosis based on a T-score of less than minus 2.5 or a T-score of less than 2? Is it rather a Z-score of less than minus 2.5, a Z-score of less than minus 2, or neither of these? So think about that, see if that's clear in your minds, and as we go through the talk, it should be clarified. Just a little bit of a word about bone mineral density, so and how we measure this. So we use the DEXA, which is dual energy X-ray absorptiometry. So a bit of a mouthful, so we'll just say DEXA. DEXA measures the amount of mineral content per unit area or volume of the bone, and call this then the bone mineral density. This actual test, or this radiation or this X-ray, is fairly innocuous, and there's a minimal exposure to radiation. It's said to be about the same as taking a flight to Cape Town, what you're exposed to. So you can then actually tell that to your patients. Some patients are worried about these types of things, and that shouldn't be a worry here. When the bone mineral density is reported, it can be reported in either T-scores or Z-scores. The T-score is used for postmenopausal women. And what this T-score does is it basically relates your patient's bone mineral density compared to the mean for the younger, healthier adult, and that's around the 40-year-olds. A Z-score is then used for the premenopausal woman, and that's for women younger than 50, and it is compared to an age-matched population. And it's just important that we realize that as we interpret these these reports that we get and make sure actually that they've also been reported correctly. Because if you see a patient that's premenopausal and they come with a T-score, their reading is going to look worse on a T-score than a Z-score, and often this causes undue anxiety. Another thing I've just popped in here to note is that athletes that participate in weight-bearing sports should have about a 10% higher bone mineral density than a non-athlete. So they should actually come with a higher bone density, not a low bone density, if everything's going well. Okay, quick word about our postmenopausal women, just to put the premenopausal woman in context. We know that osteoporosis in our postmenopausal woman is really common, or osteopenia, and that there's a really good, well-defined relationship between their bone density and their future fracture risk. The lifetime risk for osteoporosis in white women is said to be at least 40%. And with every 1 standard deviation decrease in bone mineral density, their fracture risk actually doubles. The other thing is we've also got really good data on the osteoporosis medication and how it reduces fracture risk. So it's quite a clear, well-studied field. When we get to our premenopausal women, it's really pretty unclear. And we don't know, we can't predict the relationship between their bone mineral density reading and their risk of fracture. And because of this, we cannot then extrapolate the same thresholds and treatment guidelines for postmenopausal women to premenopausal women. We've got no longitudinal studies that actually give us any insight into this. So what, in contrast again to the postmenopausal woman, a low bone mass or osteoporosis is actually fairly uncommon. And active bone loss even more so. If we find active bone loss, invariably this is due to an underlying secondary cause, and so we've got to be very vigilant and we've got to look for this. How do we define a low bone mass? This is a bone mass that, as I said, a Z-score is below expected range for age, so it's age matched, and that's using a Z-score in our premenopausal woman, and we use the cutoff of 2 standard deviations. A little bit later, I will come back to it, but in our very younger adolescents, sometimes we look at -1, but that is a little bit controversial. How do we define osteoporosis? So osteoporosis, here the diagnosis is not made on the basis of the bone mineral density only. Rather, a much stronger call for the diagnosis is the history of a low trauma fracture. And this is in the absence of another bone disease. And this fracture, with or without the low bone mineral density, actually qualifies for a diagnosis. We can, though, consider a diagnosis of osteoporosis without a fracture if we've got that low bone mineral density of -2 standard deviation Z-score in the presence of secondary causes or known significant risk factors. Several studies have really reported that a lower bone mineral density in our premenopausal women is shown to be increased with fractures. However, the short-term fracture risk is low. So a low bone mass in absence of fragility fractures, as I've said, and it's just really repeating this, does not imply osteoporosis or necessarily an increased fracture risk. This may just reflect a normal variation. If we just look at the official position, the ISCD official position, and we cannot, this is just saying we cannot use the postmenopausal WHO classification to our premenopausal women. So for our premenopausal women, as we said, we use our Z-scores rather than our T-scores. We use a Z-score of -2 or lower, and as I said again, we don't make the diagnosis just based on the bone mineral density. If we then have to look specifically at our female athletes and just looking at the prevalence of a low bone mineral density in them, It said that between 20 to 50% of our female athletes actually have a low bone density. And if you remember, they should really, if they're in a weight-bearing sport, have a higher bone mineral density. In one study of 187 elite female athletes, and these were actually runners, they showed that 10.7% had Z scores of less than -2. And then in another study of professional dancers, 23% had Z scores of -1. And here, why they use -1 is the age group of the dancers was younger and they were more adolescents. And then obviously the prevalence is going to depend on the sport. So you're going to see, you know, the sports where a lighter weight is in your favor. Often we see it there. Okay, so why should we find a low bone mineral density in our patients? And if we're finding it, why is it happening? There are two major reasons. And the first one is the commonest reason, is that they have a low peak mineral density or a peak bone mass. And what this refers to is the maximum bone mass that is achieved in life. This is usually achieved by the early 20s, and its large proportion of it is due to genetics. This peak bone mass, though, sets you up, as we said, sets you up for life in future. And obviously, if you're going to have a low peak bone mass, you're going to be a lot more vulnerable in the future. And so it plays a major risk factor for postmenopausal osteoporosis and fractures. And then there's the active bone loss. If we just take a closer look at peak bone mineral density, as I said, largely genetically determined, about 75%. Other factors, there's some inherent factors like your age, gender, your build, body bone size, your ethnicity. Then some of the more extrinsic factors, so the environment that the bone finds itself in, is it exposed to toxicities like smoking, alcohol, toxic drugs? How much exercise is it exposed to? Is there a disease in between that stunts things? Are there adequate hormones around? And is nutrition adequate? This just highlights again the importance of this peak bone mass. 60% of the risk of developing osteoporosis can be explained by the amount of bone mass accrued by early adulthood. And that's a really large proportion. This graph here, if you have a look at the curve and look at the solid curve, this depicts basically the bone mineral density over the decades of life. And you can see that there's a sharp increase in adolescence between 10 to 20 years. Then you can make some gains. And so sometimes people actually peak a little bit later, closer towards 30. Then you basically try and maintain it. You get to menopause, where there's a bit of a sharp decline and things then seem to taper off. If you have a look at the broken line, this is where the individual hasn't actually been able to attain their potential, their full genetic potential. And so they're below, and then their graph obviously will be below the whole way. And when they reach menopause, they're already starting off from a lower point. And so it's much more likely that they will have a bone density in keeping with osteopenia or osteoporosis later on in life. If we look at the bone mineral density readings in these younger patients, and those are those with a low peak bone mass or those with an active bone loss, the same reading in these patients does not always imply the same fracture risk. And this is because there's two different mechanisms. So in the low peak bone mass, this is a stable, low turnover state where you just haven't reached your potential. Whereas if in the bone loss, there's been active bone loss, and this is associated with a high turnover state. And obviously that would then be a lot more risky for fracture in the future or even in the near term. And so it becomes important that we can make distinguish between the two, especially when the patient comes in and all we have at that time is one single DEXA with readings. We need to try and tease out what is actually going on. Here, this just depicts that for you. If you have a look at the normal bone with the lovely trabeculae, that's bone that's associated with a low peak bone mass. Whereas if you look at a high turnover stage like osteoporosis, you've lost your trabeculae, you can see why that bone is then at risk of fracture. Okay, so how are we going to make the diagnosis? Firstly, is there actually a problem here? Is it a normal variant? Have we got bone loss? We have to have some strategy. When do we justify doing a DEXA scan? So not everyone that walks in requires a DEXA scan. And these are just a few guidelines, international guidelines. So anyone, they say, that has been subject to a low trauma fragility fracture should probably have a baseline bone mineral density. If the patient is known with diseases or conditions that are associated with high turnover states or low bone masses, then they probably also should. If we've had a patient come in and they're fractured, or they've got a history and we're considering osteoporosis medication, we certainly need to, because it's also a way of following them up. And then in our women that are menopausal, around menopause, and in that transition phase, we don't always wait till they're 60 to start. If they're high risk, so they've got known causes or red flags, things like a low BMI or previous low trauma fractures, or they're on toxic medications, bone toxic medications, then we also are more inclined to do a DEXA. We've got to do a bit of basic biochemistry. Here we would look at a full blood count, a UNE, so renal function, as well as our calciums, phosphorus, vitamin D is very important. Remember, we need an adequate calcium and vitamin D, the building blocks for mineralizing our bone. Thyroid status, and then we also look at a 24-hour urinary collection, looking at their calcium excretion. Do we use markers of bone turnover? These are quite costly, and yes, they do have a role, but not such a common role. We need to be cautious if we are using them, that we're going to be able to interpret them. We need to be aware of the fact that there's a great variation between in the ages. There's quite a large normative range in our younger women. The assays are quite poorly standardized as well. And if our patient has fractured, this also changes these markers. But they are, having said that, they are useful, especially in those patients where all we've got is one DEXA. If we do them and the markers of turnover are raised, then we can actually decide that we've got active bone loss going on, and this helps us predict fracture risk and whether we need to treat. We can also use them just in following up our patients who are on treatment where we're worried about treatment failure, and just to see, are they actually responding to treatment. As I said, that bone loss is fairly rare, and if it's there, there's a secondary cause. So we have to have an approach, and we have to be thinking about these secondary causes. There's quite a large list. There's starts with inherited, which I'm not really going to go into because that should have been picked up during the childhood years. Then the nutritional causes, some malabsorption, that could be something like celiac disease. So if you find a patient, you've done the biochemistry, they've got a low calcium, they've got low vitamin D, sometimes they've got low ions, other things, then we actually look for that. Looking at the endocrine disorders, most importantly, or very common, is the hypogonadism, hypothyroidism, and I've highlighted the anorexia nervosa, and that's under an endocrine disorder because it's not just the nutritional part and not just the hypogonadism, but there's a whole cascade of endocrine abnormalities that occur from it that we'll look at it a little bit closer. We go into a review of medications. If we look at the medications, there's quite a long list. More commonly in our athletes, sometimes it's the use of glucocorticoids. Speak to them about contraceptive use, especially the progesterone-only contraceptives. Then our mood drugs, our SSRIs can even be bone toxic. Sometimes people are abusing their thyroid medication. And then importantly, the use of steroid-enhancing drugs. All of these things not good for the bone. Speaking about hypogonadism, because this is a major problem, and I just want to define the difference between primary amenorrhea and secondary amenorrhea. So primary amenorrhea is when there is a late menarche, whereas secondary amenorrhea is where menarche has happened at a normal age, but now we've had missed cycles or we're not regular any longer. Another form of hypogonadism, and I mentioned that, was our progesterone-only or injectable contraceptives. So these are a problem when they're used in our adolescents because they haven't attained that peak bone mass and they need the estrogen to do so. They're also a problem if they're used long-term, so longer than 2 years, especially in individuals with a low body weight. The good news is that most of the effects are actually reversible when it's discontinued. But obviously, if it's used in your adolescent and it's discontinued, you're still going to lose out on that window of rapid bone increase in attaining their full peak bone mass potential. We don't have any good data or literature on the actual impact on fracture risk. Then taking a look at the oral contraceptives. So this is generally viewed as being bone sparing, the estrogen. However, there's a word of caution not to use it too early. So they say not to use it within 3 years of menarche. And there is some concern also with the dosage. If it's less than 30 micrograms, then we're not going to be able to effectively build bone. Again, no clear data on the relationship with fracture risk. This brings me, all of this kind of leads to a topic called the female athlete triad, which I'm sure a lot of you have heard of or might be quite au fait with, and it's actually really common. When we have a relative energy deficiency in sport, this then leads to a disruption of the hypothalamic, pituitary, and ovarian axis. So we have low energy availability. This then leads to a low estrogen. At the same time, it directly leads to a low bone mineral density as you're not in an anabolic state. The low estrogen also in turn leads to the low bone mineral density. And this is just a very simplistic view of it. If we have a look at this diagram, it puts it in a bit more detail and in a 3D kind of version. So having a look at the bottom in the red, you can see that triangle has all three of the components. So it's got the low energy availability, it's got the amenorrhea, and it's got the full bone osteoporosis. It's not common that all the patients meet all three of these, but rather that they are on a continuum, somewhere between on the black lines towards the green triangle, which is the normal status. So they may have not a full-blown eating disorder, just reduced energy availability. You may have some athletes that are just not taking in enough for the expenditure and it's not purposeful. They may have subclinical menstrual disorders. So it may just be a late menarche that they're not even aware of as being abnormal. They may not currently be amenorrheic. And they may not have a full-blown osteoporosis. It might just be a slightly low BMD. So they're somewhere on the continuum. The important thing is to be able to pick them up on this continuum and to try and shift them up towards the green area so that we don't have them in this danger red zone. Ideally, energy availability of 45 kilocalories per kilogram of lean body mass is ideal for the athlete. But they've said that this is fairly unrealistic and we're not actually going to reach that target. So they put a cutoff of 30 kilocalories. And when they're above that, it's said to minimize the negative effects on the bone. So when we have an energy availability below the 30 kilocalories, what do we see? We see a decrease in bone protein synthesis as well as mineralization. There's a decrease in insulin, which enhances amino acid uptake. There's a decrease in insulin growth like growth factor 1 and a decrease in T3. And this all really amounts to a hypermetabolic state. So it's not just a lack of estrogen. Here we have a full summary of all the consequences of this triad. And this ranges in pink from all the physiological to green, the psychological, all the way through to gray. If you look at the gray, these are the long-term health problems. And at the top, in capitals, is osteoporosis. So this is one of our long-term problems. The problem with it being a long-term problem is it's really not recognized by the athlete. It's not real to them, and it's in the future. So it's not an urgency now. I would like to just highlight the yellow block, because the yellow block is what we can use to motivate our athletes. And this is the effects on their actual performance, injury, and recovery. So if they understand that is this actually leading to a decreased energy and early fatigue, that it's actually influencing their performance, they've got decreased coordination, concentration, and speed. They're going to have more frequent injuries, muscle strains, sprains, and fractures. They're going to actually fall ill with flus and colds more often and take a longer time to recover. That we can actually use as a great motivating tool, I feel. We need to be screening, otherwise we're going to miss this triad. And in the British Journal for Sports Medicine, they put up some questions. There are quite a lot, but they do, if these questions are asked, you should not miss, you shouldn't miss the triad, and you shouldn't miss them on the continuum. You should be able to pick them up, red flag them, and see. So a lot of it does revolve around their menstrual cycle. Have they ever had a menstrual period? If so, how old were they? When was their last menstrual period? How many have they had? Are they skipping cycles? Are they presently taking any female hormones? So often, you know, you just ask them, are you regular? Yes, but they're actually on a contraceptive that's controlling their cycle, and then we're missing it. Do you worry about your weight? Are you trying, or has anyone recommended that you gain or lose weight? Are you on any special diets? Have you ever had an eating disorder? And you actually have to ask this one directly, because often it's brushed off and it's not going to be told to you unless you ask for it. Have you ever had a stress fracture? Have you ever been told you have a low bone density? So if we ask these, we should not miss it. Just spending some time specifically on anorexia nervosa. And this, we see the peak incidence of it occurs in our adolescent athletes, but not to say it's not in the other age groups. Anorexia is commonly accompanied by a low bone mass or osteoporosis. And this is then aggravated by excessive exercise programs. So either you've got the anorexic who's doing the exercise to help control the weight, or you've got the athlete who's suppressing or not eating in order to keep their weight down for the actual performance. The horrible part about it is that there's actually really early rapid bone loss, and this is within 6 to 12 months of losing their cycle of not getting in enough nutrition. And as I alluded to before, there are many mechanisms for bone loss. It's not simply just the loss of estrogen. This is a whole endocrinological disorder. The little picture that I put up here is of a vertebral compression fracture. This is in a 25-year-old who was using dieting and endurance running in order to maintain her weight. So that just illustrates that. In our anorexics, they do qualify for a DEXA, bone mineral density, especially if the eating disorder has been around for at least 6 to 12 months. There's a strong correlation between their bone mineral density and the actual duration of their amenorrhea. Giving these patients hormones, so an oral contraceptive, is not the answer. And I've had that where the mom brings you in and we think it's going to sort out the problem and be a quick fix. But most studies have actually shown that there's no improvement in the bone mineral density with the hormonal therapy. You have to actually sort out the underlying nutrition. So as I said, it's not just due to low estrogen. There's a whole host of issues here. So what we mentioned before, a deficiency of insulin-like growth factor, low androgen levels, hypercortisolemia, increased osteoprotein, reduced leptin, and then a disordered ratio between ghrelin and atorvastatin. Okay, here's just one other subgroup of our athletes that I thought we should include, and that's the aging athlete, especially since we are facing an ever-growing aging population. And as we've said, osteoporosis and osteopenia are common in this age group. A lot of them are exercising, and so we're going to see more and more athletes, older athletes with vulnerable bone exercising. This age group, they tend to pick endurance activities, especially long distance running. And these are easier for them to actually be able to do because they involve less impact. They involve less muscle bulk used for more explosive short duration exercises. But the problem is here, repetitive stress on the older bone will be higher than that for the younger bone. So they're exposed to more stress. Taking a quick look at our stress fractures and bearing all of this in mind. So a stress fracture, just to start off with, what I'd like to say is that a stress fracture can occur in an individual with normal bone without an abnormality if the strength and the repetitive forces are strong enough. However, in our athletes, they require, yes, a stronger bone, but if they are training in such a way that they're doing the multiple repetitions, they gradually build up and improve the strength in the affected bone, that actually they shouldn't be having an injury. If, of course, their actual bone strength is vulnerable and is compromised due to all the things we've been talking about, then they will not be able to adapt, and then stress fractures will occur. So some risks for stress fractures, intrinsic risks, are our female sex, a low bone density, the female athlete triad, and nutritional deficiencies. Then looking at our extrinsic issues, I would probably guess that the attendees might know a bit more about this than me being a physician. But the type of sport, the training changes, the terrain, recovery times, and then shoes. Here we have some data from a study where they had a look at stress fractures in younger female athletes with the athlete triad. And you can see there they've got the 3 circles, each one depicting each part of the triad. And the most common association between a fracture of the triad was amenorrhea. And you can see that only 5.3% actually in the middle there had all 3 parts, met all requirements for all 3 parts of the triad. And so that just highlights again that they don't have to have everything, but they're still at risk. Here we have a study where they had a look at the incidence of stress fractures in amenorrheic athletes compared to eumenorrheic athletes and non-athletes. There was arm A where they looked at all types of fractures. I haven't actually put that up, and that's why they had non-athletes, because they featured here, but they don't feature on this one where they're doing only stress fractures. So if you have a look, it's pretty obvious with the solid columns that the amenorrheic athletes are at highest risk, except around 13, and that's where they say that the muscle mass may not have yet be big enough to counteract, and so there your eumenorrheic athletes could actually be at as much risk. But then as the muscle bulk improves, it's more the actual bone that determines it. I'd now like to move on to management of this. And before we even speak about management, I think we just need to recognize the sport ethic and recognize that these are athletes that are actually over-conforming to this ethic. And if you recognize what the ethic is, then you can work with the problem. So the athlete makes sacrifices for the game. The athlete strives for distinction. They accept risks and they play through the pain. They accept no limits in the pursuit of possibilities. Okay, so top of the list, dietary adjustments. So adequate diet, training adjustments, counseling, and this may involve individual, group therapy, family therapy, especially in our younger athletes or where there's adolescents with eating disorders, and they may even need to be entered into an eating disorder program. And last of the list is medication. So that's right at the bottom. This requires a strong interdisciplinary team, and the doctor is only one little square at the top. So very important that when they present to the doctor, we cannot solve this on our own, but actually the rest of our team is really important and probably more important. I will, because I am a physician, give you just a little bit of a view of the bone-specific therapy. And just to start off and say that it's, you know, it's more for our postmenopausal women. So in our premenopausal women, it's reserved for really two issues. Those are the women with fragility fractures or those that have a low bone mass with a confirmed active bone loss with a secondary cause that is ongoing or not treatable. So you're not winning in actually treating that underlying cause, so the anorexia and the fracturing. There are great safety issues. We don't have data of any of these drugs really in premenopausal women. All the studies on the drugs are done in postmenopausal women. The other thing is our women are of a reproductive age, and these agents are not safe for pregnancy. So we've got no efficacy and we've got very little approval. And so we have to look at each case on its own and the merits of, and we need to then obviously apply what the benefit versus risk here, and always obviously a really high benefit versus risk. Of our therapy, there's three main classes. Bisphosphonates, I think most people have heard of, and they have a little understanding of them. They are used as anti-resorbers, so just to slow down the bone turnover. They hang around in the bone for a long time. So people say they have a legacy effect. So if you give it, it's going to be there for a while. You need to know that, especially if the patient wants to fall pregnant or is thinking of starting a family. We then have two other drug classes, teriparatide, an anabolic agent, and denosumab, one of our monoclonal antibodies. So I'll quickly just tell you a little bit about those. So looking at denosumab, this is, wait, I think I've skipped to, okay, denosumab. This is a monoclonal antibody, and it basically just is, it competes with your rank ligand. Rank ligand is what stimulates your osteoclasts to resorb the bone. So this just competitively binds with that, and it shuts off the osteoclast bone resorption. I seem to have a few of my slides are gone, but that's okay. I think you will have, that's fine. I've spoken about it. All I did want to say about the teriparatide was that it's our only anabolic agent. It has got some specific roles. It is FDA approved in our premenopausal women when they have got a glucocorticoid associated osteoporosis, but no other approval. There are some papers and reports, quite a few good ones, where there's anecdotal evidence that it helps with where there's delayed fracture healing, especially for stress fractures. So that there is a role for it there. Patients are limited to an 18-month course per lifetime. So it's just to bear that in mind. Okay, So importantly, in the premenopausal woman with an isolated low bone mass, medication really is usually not where we start. We promote good bone health, and we try and adjust the lifestyle. And if we can do a watchful wait, and we can repeat the bone densities and see where we are. I'd like to now just go through some case studies, and I'm hoping that this will just tie it all together for you and just bring through the themes. Okay, the first patient I want to introduce you to is Mrs. T. Mrs. T is a 35-year-old triathlete. She presents with a left basicervical neck of femur fracture. She sustains this injury during an Ironman contest. She's able to at the start of the run, she feels her hips snap. And that's what it looks like. But if we go back and we chat to her, she says she's complained of the pain in the preceding weeks at the hip. She also had pain in the lower back. She went to see an orthopedic surgeon who injected both her trochanteric bursa as well as her SI joints. She even went for an MRI 2 weeks prior to the triathlon, and she was given the all clear. In her background history, we need to note that she had previously undergone a left labral repair the prior year, and this had been prompted by severe hip pain. There was also a past history of a stress fracture of the hip, but she said that this had settled with rest. At the time of surgery of repair, the surgeon noted that the fixation was actually quite difficult, as that femoral neck was smaller than the other side. Post-operatively, she's still complaining of back pain. And this is the same pain she had been experiencing prior to the triathlon. An X-ray is done, and here we can see a compression fracture at L1. A biochemical screening is done, and we don't really find any other causes for biochemically. She's correctly then sent for a bone mineral density, a DEXA. And if you have a look here, we've circled the Z-score, and it's interpreted correctly upon the Z-score. If you look at her lumbar vertebrae, AP spine, L1 to 4, this is -2, and so this actually fits with a low bone mineral density of her age group. Have a look at her distal third of her forearm, -5.9, so that's quite a severe reading. On her bone mineral density, and this is pretty much standard with DEXAs, they have a look at the lower thoracic and the lumbar spine, and they do a screening for vertebral fractures. And when this was done, they comment on that fracture at L1 that we had picked up on X-ray, but they found another one at T8. So she's actually now had 3 fractures. Let's take a closer look at her background history. She's had quite severe nutrition issues. So she's had an eating disorder of anorexia nervosa diagnosed around 12, 13. And remember, we said that you gain most of your bone between the ages of 12 to 15. So that's your critical time. So she's probably now actually had a low peak bone mass with ongoing bone loss. She's also had bulimia at age 20. And when you chat to her, she's actually got an ongoing disordered eating. And I just want to here highlight between an eating disorder and disordered eating. So an eating disorder is where they fulfill the criteria for the classical anorexia and bulimia. However, disordered eating is where you're not getting in adequate nutrition. And that can just be where you're fasting in between, you're binging. It's just, yeah, so it's quite a range. And it's actually, there's a large proportion of people that fit into that. She's been diagnosed with depression since the age of 50, and she suffers from gastroesophageal reflux disease. Here's a list of her medication. She's on a PPI, Trustan. This can also be considered as a low having some low bone toxic effects. She's on Nuzac, which is just a form of fluoxetine. She's on Epitec for her mood. Epitec is part of our anticonvulsants, so that would be bone toxic as well. And then she's on hormones, Mercilon. Okay, so when we make a diagnosis, we can correctly diagnose Mrs. T as having osteoporosis. And this would be defined by her low bone mineral density with the presence of the multiple fragility fractures. And as I stated, this is probably on the background as well of a low peak bone mass. Underlying causes for this diagnosis, the eating disorder of the anorexia nervosa, she also had the bulimia, the ongoing disordered eating or reduced energy, and then the exposure to the toxic drugs. So what do we do for her? Mrs. T fulfills that criteria, and because of the severity of her disease and the osteoporosis, she actually does require osteoporosis-specific treatment. And because it's quite severe, we decide to choose the anabolic agent teriparatide. She's also at this stage very wary of using a bisphosphonate and its long-term side effects. So she successfully completes an 18-month course with good compliance. So just like a motivated athlete, she does this well for us. At the end of her course, she is given a bisphosphonate, and this is important. So at this time, we had to chat to her and discuss things with her. You do have to follow up, and that's a trick with the teriparatide. It has to be followed up with an anti-resorptive agent, because otherwise you stand to rapidly lose the anabolic effects of the teriparatide. And at this stage, 18 months later, she decided she's actually finished with her family. And yeah. So on follow-up bone density, this is what we get. And this, again, has been correctly reported in Z scores. And if you have a look at her AP span, so that's a lumbar span L1 to 4, you can see that's increased from -2 to -1.6. And if you look at that distal arm, remember that was -5.6. There's a dramatic increase here to -0.8. So she's had a great response to therapy. And we can maybe pat ourselves on our back, but actually we can't. Because of great concern is, as she recovers from her fracture, she starts training again. And we start to see a continuous decline in her weight. So over the 18 months, we see a 9-kilogram loss of weight. She also has, in the meanwhile, stopped her Mercilon, and she reports amenorrhea. Clearly, she's got an ongoing disordered eating, or even an eating disorder at this stage. We ask her to follow up with a psychiatrist as well as a psychologist. Learning points from this case, and for myself really, is that we didn't follow the interdisciplinary team. And in some ways, I feel I failed this patient because if we had given her that, she would have had more support, and hopefully she wouldn't have ended back at the starting point of bone loss. All right, so that's just, for me, was an important learning point. Our second case is Ms. R. Ms. R is 38 years old. She considers herself a natural runner, and she has begun training for long-distance marathons. But she now presents with a metatarsal fracture. Importantly, 2 years previously, she had sustained a stress fracture of the left femoral neck. And this had healed. She had stopped training, and she said she had followed a careful course of restarting her training. Her background history, she has a bipolar mood disorder. She's also known to have probably had an eating disorder. And this actually, I had to tease out of her. She admitted a TARA admission for bulimia at the age of 16 years, but she said to me this wasn't really a proper eating disorder, and she wasn't skinny like all the other girls. However, when we asked her what her lowest weight was, she did claim that she had a weight of 45 kilograms, but said there was no amenorrhea with this. So as I said, a continuum, they don't always meet all 3 criteria. Other background, she's hypothyroid and she's been adequately replaced. I didn't find over replacement. Family history, mom has osteoporosis, and remember that genetics make up a large proportion of the peak bone mass. She smokes, and obviously not good for the bones, about 5 a day. She also has a chronic history of iron deficiency. This could be significant in terms of bulimia, but it is also known as a side effect of reduced energy and as well as anorexia, one of the physiological effects. If we look at her medication, there's quite a long list here. So she's been on lamotrigine for mood stabilization since 16 years old, again, bone toxic. She's previously also used Epilim, another anticonvulsant, and is now on Topremax, all of those bone toxic. She uses Remeron, which is a mirtazapine. She's on an SNRI. She takes Revitol, and then she's been using memansamine. And she says to me that she admitted she's using that really just to curb her appetite. She again is on a hormone, Jeanette, so you won't then pick up the hormonal disturbances. She's on the euthyrox for hypothyroidism, and she's taking some vitamin D3, which is good. Her biochemistry workup is normal. We don't find any secondary causes. Because of all her risk factors and because she has had a stress fracture, a bone mineral density is appropriately performed. This was normal. However, what it was concerning was the fact that she appeared to have ongoing disordered eating with a poor insight. So what did we do? We managed her from a conservative but multidisciplinary approach. So I referred her to a sports orthopedic surgeon to help her with a safe recovery and return to play. She was referred to a nutritionist. We asked for a psychiatry review and also asked for the psychiatrist just to look at her meds in terms of her bones, as well as a psychologist review. And we're hoping on follow-up to see some improvement, positive improvement there. Okay, our last patient is Mrs. H. Mrs. H is 35 years old. She has recently started running and training for long-distance marathons, and she actually then entered the Comrades Marathon, where she sustained a left proximal femoral shaft stress fracture, which was picked up only on MRI. Her background history, again, bipolar mood disorder, also query a history of an eating disorder. She is known to have a low BMI in the past, but again, played this down. Her current BMI is 24. She tells me that when we ran through risk factors, and one that I actually didn't highlight earlier was caffeine, that she has previously been a caffeine junkie. Caffeine, again, is bone toxic. In her family, there is also, again, a history of osteoporosis. Her medications, Epitech, which, as we've said, is anticonvulsant. She's been on that for 2 years, bone toxic. She's on Xylift for the mood, so we said an SSRI is also not great for the bone. She's previously been on Ritalin. Whether this has been used to also bring down her weight, we can question. She's on Melodine, so another estrogen, which would, again, mask any cycle abnormalities, on vitamin D3 and on a calcium supplement. If we have a look, and correctly again, she's referred for a bone density. If we have a look at her bone density, correctly reported with a Z score, we will see that her bone density is actually okay. She doesn't meet any of the criteria for low bone mineral density. On her biochemistry, also no secondary causes found. We did do some markers of bone turnover because here it was tricky, and all we have is a single bone mineral density. And these were, as I say, they can be quite difficult to interpret. We looked at her beta cross-laps, which are used as a marker for resorption. And then we looked at a marker of bone formation, which is your bone-specific ALP. And we decided to just manage her conservatively. However, we found that there was delayed healing. She complained of ongoing pain and she was unable to weight bear. We repeated the bone markers and we saw no changes in them to indicate fracture healing. She became more agitated and anxious, and this was not good for the mood disorder or for the eating. The surgeon offered her insertion of a rod, which she turned down. She also expressed to me that she was thinking of falling pregnant in the near future. So now we had to make a decision what to do. What we did here, and I will just put a disclaimer in, this is, it is not approved, but it is done, or it's part of the novel anecdotal therapies, is we used the teriparatide, so it's off-label, and we used it as an anabolic agent just to kick in the healing. It is quite an expensive drug, and it costs around 5,000 Rand per month, and that was an issue for her as well. So she felt she could afford 3 months, and we thought that that would be enough to kickstart the healing, and we actually were successful. Okay, thanks. So those are just my contact details. If anyone has any questions or anything they'd like some further information on. And then here we've got some helpful articles. You can just take a screenshot of that if you would like to refer to them. They're quite good reads.
Hayley, thank you very, very much. That was a wonderful, wonderful presentation. Very, very complex topic, as you've indicated. I really want to thank you for going in depth into it and for following it so logically. I think it put everything into perspective for us, and I think woke us up to how complex these issues are, not to brush off these stress injuries which you might come across or the potential eating disorders, and also for emphasizing the importance of that multidisciplinary team. I think that's very, very important, and in your case studies that came across very clearly, that we need to consult each other, and obviously that's one of the objectives of WISH, is to try and work together between disciplines and establish those connections and communications a lot better. So thank you for emphasizing that. A few questions, some specific ones have come through, and some general ones as well. Just in terms of supplementation in our athletic population, is there anything particularly for our females that you think they should be on as a standard? So I'm thinking about things like iron, I'm thinking about calcium, I'm thinking about vitamin D. Should we be doing anything prophylactically?
No, so it shouldn't be standard or prophylactic. So it's got to be tailored. So especially with vitamin D, it was fashionable some years ago to put everyone on vitamin D, and we've had to rethink that. The evidence is that there is no benefit unless the individual is actually deficient. And they even some while ago changed the normative ranges of the vitamin D. So you have to actually be checking the vitamin D if you're going to be giving vitamin D. So we shouldn't just standardly be giving that. It's not necessary. And if our athletes are training outdoors, they should actually be getting vitamin D within our climate. Unless, of course, as I said, there's a malabsorption going on. In terms of calcium, it is vital that they get enough calcium. First port of call is always diet for anyone. And then after that, you can supplement. So it depends really on their diet. There's quite a nifty little app that you can use. It's put out there by the International Osteoporosis Foundation. They've got a little calcium calculator. And you can actually download that app, and you can plug in your details, and it gives you your diet, and you'll actually work out how much calcium you're getting in and where your deficiency is. So if you're short so much, most of the supplements are about 400 milligrams. And we don't like to really give people more than 1,000 milligrams per day. And that includes obviously dietary intake as well. And then iron, again, unless they're iron deficient. So if you're dealing with someone with poor nutrition, then you're going to need to. But in a healthy athlete, you shouldn't have to.
Okay. A question from one of our colleagues who looks after national rows, and she talks about having to make weight limits. Now that's something that's quite common in sports, that you have to make certain weight categories. Now that may, from an eating restriction perspective, raise a few flags and increase their risk. She's asking, should she be doing DEXA scans as a routine in terms of screening these athletes? And we might extend that to other sports, for instance, in cycling, where there's a very low weight-bearing element, and in particular in cycling where they fall quite a lot and are at risk of fractures and need to look after their bone health. So in those sports where there are risks and where there are potential weight categories they have to make, is it worth perhaps lowering your threshold for DEXA scanning?
You could lower it, but again, I think it's on an individual basis. So I don't think you can just make a blanket recommendation there. But yes, those sports, definitely, it is an issue, and there is an increased risk, obviously. Sorry, but it's not, I wouldn't make a blanket statement. And then with our cyclists and also like our swimmers who do not participate in impact, they should be doing cross training as well. So as their trainers should actually be bringing that in to try and help them. Yeah. So I think you've just got to watch the actual individual.
Okay, perfect. In terms of some of the specific questions that have come through, there's a very specific question about Turner's syndrome with low bone mineral density. How effective is exercise in improving that mineral profile, bone mineral profile?
Well, exercise is effective in any individual. So I don't think that it would be any different for Turner's. You know, they need to be getting hormonal exposure, and to hormonal exposure with exercise, then you can build it. And if it fits the criteria for the exercise, or what we've said, you know, the plyometric resistance, impact loading, then that will help.
And then in our screening process, you put up some nice screening questions there that we should be asking our athletes in terms of their bone health. How important are genetic factors, inherited factors? If you've got a mother, a sister who was osteoporotic, should that be brought into the equation? And if so, what are the precautions that we should be taking for those athletes who are participating in impact sports in particular, like running?
Okay, so those are important. As we said, when you look at just the peak bone mass, it's about 75% of it is genetic. And when you look at osteoporosis, there's a very strong genetic component. So patients with that can be considered as a risk factor. But we don't do bone mineral densities purely based on that. If they flag with another risk factor, if they've had a stress fracture, together with that, then we are more cautious. Or if they're now transitioning to menopause, that would be one of those risk factors, and then we'd like to get a baseline. And we wouldn't wait for 60 years old, because the NOFSA, the National Osteoporosis Foundation of South Africa's guidelines are that we actually only screen from 60 years old. So this is a different population, and you can't just, so it's not just a blanket screening. They've got to have indicators. And a family history, I don't think, is enough at that age without another thing going on.
Great. And then in your terms of your DEXA scans and your reports, the report you put up was very detailed, looking in particular at the forearm, etc. You don't always see that on all reports that we get. So I just want to ask, is DEXA scanning a standard process in terms of the technology and in terms of the reporting? Or does it vary from unit to unit?
It does, and it shouldn't be. So, you know, every second year, NOFSA actually run a whole DEXA scanning symposium, because it should be standardized. But we found that there are quite a few poor quality reports coming out there, and unfortunately they're not always actually reviewed by the radiologist. It's more the radiographer or the machine spitting out the thing. We see it where, for instance, men, we use a woman's the women demographics we actually report on for men, and some of the machines, they just haven't updated the software or set it up that way, and so things are getting reported badly. The other thing is, in most of the reports that I get, they give you an average for L1 to L4, and actually you need each one separate one, L1, L2, L3, L4. When we make a diagnosis of osteoporosis, it's on just one single site being within that score of lower than -2 in the premenopausal or lower than -2.5 in the postmenopausal. So an average, if they give you an average of L1 to 4, you may miss a reading in between there that's actually meets the criteria. So that is a great area of concern. and the doctor interpreting it needs to be wise as to how to interpret it, and needs to actually, you can't read the blurb that's given there. You need to look at things yourself.
Okay, great. Fiona Bays is asking about your case study and the amount of caffeine that athlete took. What would you regard as a problematic amount of caffeine? And, you know, if they do stop that, and that's a major contributor to their bone density loss, how long will it take to turn that around?
Okay, so firstly to say, I don't think it's a major contributor. These are just, you know, it's an environment that you're creating for the bone. I can't tell you how long that's going to take to turn around exactly. I don't think we have any data on that, but it's a large amount. And again, it's hard to quantify, but this athlete had been taking many coffees as well as energy drinks. It's quite significant. So it's not someone that's having 3 coffees a day. It's
Right.
It's a lot of caffeine.
Okay.
And
Someone
that's
asking
coupled
about,
with other.
okay, vitamin D3 deficiency as a risk factor. I think you've answered that. But iron deficiency, as I understand it from your presentation, is more of a reflection of disordered eating and perhaps deficient intake rather than a risk factor in itself. Is that correct?
Correct.
Yeah. Then we've got a question here from Zach van Heerden, who's an exercise physiologist, asking about the link between synthetically derived supplementation, specifically meal replacements and in-training boosters in athletes in high volume training and poor bone condition. So do you know of any risk factors in supplementation, supplements, commercial supplements?
When we look at nutrition, and what we do find with the nutrition of, for instance, the female athlete triad, we often find that they have a very high protein intake, and the protein is usually in terms of meat and not dairy, they favor. And that is actually, that's not great. So then they miss out on the dairy, which they need. And the high protein is, you know, they miss out on the calories, and it's not favorable.
So it's a question of balance, really. They often get the balance wrong. Yeah.
Exactly.
And then postpartum, a question here from postpartum, how long should it take for the menses to return if they haven't returned? And this would be in an athletic individual who has a baby and then wants to start training quite soon afterwards. How long should we expect it before their menses return, before we raise a flag?
Yeah, so I mean, I think it's, and I'm not a specialist on this, but I think if the menses haven't returned by 3 months, you need to start worrying. And remember, with pregnancy, there are some changes in the bone as well. The state of pregnancy actually is an increased bone resorptive state, turnover state. However, it's a reversible state. So we do see that in pregnancy, bone density goes down. So you've got to be careful with training immediately afterwards if you've already got a lower bone mineral density, but it is a reversible state, and you should have reversed it fully if everything, nutrition and everything is right, by at 9 months it should have been fully reversed. Yeah, so I think if you've got a healthy athlete and there's no underlying issues, and then they should be able to safely train. If they're unhealthy, or if the nutritions are concerned and their BMIs are concerned and the menses are not there, then obviously they're going to be at risk.
Great. One of our dietitians asking about a carbohydrate deficient state. Would that impact on bone? So there's been a trend away from carbohydrates in some individuals. Would that impact on bone status?
Absolutely, because that's that reduced energy. That's what it amounts to. And that disrupts your hormonal hypothalamic ovarian function access. And that's what I said with, especially with the ballet dancers, where they've got a lot of protein intake, but no carbohydrate.
Okay. And then finally, Lance Stevens asking about DNA analysis. It's quite trendy now to go for DNA analysis and try and see what your predisposition is to a whole gamut of conditions. I mean, is that something that's indicated? Would it pick up anything? Would it prepare athletes for this potential injury? Or have we not reached that level of sophistication yet?
I don't think we've got enough data on that to be able to draw those conclusions. As I said, genetics are important, and really that's just a good history actually picks that up. And you don't ask the patient, does anyone in the family have osteoporosis? You ask them about fractures, breaks, that type of thing, and postures, and then it seems to come through.
Okay, brilliant. And I'm going to end off with, it's not so much a question, but it's a comment from one of our very experienced physios, Evan Speechley, who's worked with a number of teams. And he mentions that we often see this pressure coming from the coaches, and I would add also from parents sometimes, about losing weight, to the extent that in the young athlete it might be regarded as a form of abuse. And that when you talk about the multidisciplinary team, I think we have to have the parents and we have to have the coaches on board as well, in terms of understanding what these risks are, and potentially even reporting that sort of behavior. Quite difficult from an ethical point of view, but again, it emphasizes the complexity of a lot of these problems. I'm going to end it there, and just to say really thank you very, very much. It was a most comprehensive presentation, very logical, presented in a very ordered fashion, and gave us a good idea of the type of complexity we should be aware of in terms of addressing these athletes. And hopefully we can work more as a multidisciplinary team in treating and identifying these particular cases. So thank you very much. And just to say that later on in the month, I think we've got a very complimentary talk from an endocrinologist from the US, Dr. Kate Ackerman, who's going to talk specifically on the Red S syndrome that you referred to, and go into a little bit of the endocrinology behind that. So I think that will complement what we heard today very nicely. So thank you very, very much, Hayley, for your time and for your preparation. Thank you all for supporting this WISH webinar again. And to our sponsors, Dita and Asino, thank you very much for being part of this. Robin Saggers in the background, managing the technical side, thank you very much. And we will promote the other presentations in a slide that he's going to put up in a second. And we look forward to you all joining us in a couple of weeks again. So thank you very much and have a good evening. Thank you, Hayley. That was superb.